Well, hello everyone, and thank you for joining us, and welcome to the National Consortium of Telehealth Resource Centers monthly webinar series. Today's webinar topic is Multicultural Patient Engagement Strategies and Solutions. My name is Kathy Chorba, and I'm from the California Telehealth Resource Center. Next slide. The California Telehealth Resource Center is a proud member of the National Consortium of Telehealth Resource Centers, which is made up of 12 regional telehealth resource centers and 2 national telehealth resource centers, one for policy and the other for technology. Together, we have formed a consortium that is designed to expand and strengthen our ability to assist you with your telehealth program development and sustainability needs. Next slide. Let's just go ahead and review a few of the logistics. Your phone and computer microphones have been muted. Time will be reserved at the end of the Q&A. And go ahead and write your questions in the Q&A box at the bottom of your screen, and that will help us to quickly get through everybody's questions and answers. And please, if you don't mind, please fill out the post-webinar survey. That helps us a great deal. The webinar is being recorded, and the recordings will be posted to your YouTube channel. So for this webinar or any of our previous webinars or our future webinars, it's good to know that you can come back and watch these at your convenience at any time. So next slide, please. And as many of you know, California's Medi-Cal population is 81% multicultural, which is a unique challenge for health systems. Abner Mason, CEO of ConsejoSano, will provide a brief overview of their culturally competent two-way text patient engagement service. This service drives increased patient engagement and improved outcomes for multicultural, underserved, and the hard-to-reach populations. Thanks, Abner. Joel Gray, Executive Director for Anthem Blue Cross California Medicaid, will share Anthem's innovative partnership with ConsejoSano, LanguageLine, and Safety Net Health Centers to launch telehealth and digital solutions. These innovative solutions help solve for cultural and language barriers in healthcare, thereby improving quality and patient experience. So thank you, Abner and Joel, for joining us today and sharing your experiences with us. Go ahead and take it away, Abner.
Thanks very much. Thank you to the whole National Consortium of Telehealth Resource Centers for the opportunity to talk about the exciting partnership that the ConsejoSano has with Anthem, and the network of clinics that Anthem has created to actually meet the care needs of their members. My name is Abner Mason, and I'm founder and CEO of ConsejoSano, and we are a patient engagement and patient navigation company with a special focus on engaging multicultural, low-income, undocumented, and other hard-to-reach patients and plan members. The problem that we're addressing is that although our country has and our state, California, where I'm based, but the whole country has become far more multicultural over the past 4 or 5 decades. But our healthcare system has not kept up with this demographic change. And as a result, our healthcare system today is just not well equipped to serve the country that we've become. And that's the problem that we are trying to address at ConsejoSano and trying to help our clients to address. We utilize technology and cultural alignment, and put a special emphasis on cultural, as you'll find out more in the presentation. We use technology and cultural alignment to improve patient outcomes, lower costs, and increase revenue for plans and providers. So what is it that we actually do? We engage patients on behalf of providers and health plans and energize them to be proactive about their health. Our primary tools to reach out to people is text messaging, and we'll talk more about that. Just so you have a sense of some of the work we do, we spend a lot of time working with our plan partners and provider partners to improve quality measures, particularly HEDIS scores for the Medicaid program, star ratings for the Medicare Advantage program. We do a lot of work trying to get patients to come in for screenings, reaching out to the members to try to get them to come in, and I'll tell you in this presentation how we do that. A lot of chronic disease management. We also, run campaigns across the whole range of needs that healthcare needs that patients face, whether it's flu and pneumonia shots or maternal health. We do a lot of work in the diabetes space, trying to get people to come in for A1C. And we're also working with plans increasingly now around issues around retention helping to keep members. And a new area that we're working with is helping to survey for social determinants. As we've better understood what the factors that really influence someone's health, we all have sort of learned that it's not always what happens in the clinic, it's what's outside of the clinic. And so a lot of healthcare stakeholders are saying, how do we get a better sense of what our patients and members are facing outside of the clinic? So if we can help them. And so we are surveying for social determinants. So those are some of the kinds of activities that we engage in. We have built a company at ConsejoSano, and this is important to the rest of the work you see. Sometimes people don't see it as important, but we do. We built a team at ConsejoSano that reflects the people and the communities we're trying to influence. Our team is 88% of the team members, our employees at ConsejoSano, come from an immigrant or first generation or historically marginalized community. 77% are women. And as you'll see in the rest of the presentation, a key goal for us is to understand who people are culturally and to use that understanding to build trust. And I can just tell you that it is a whole lot easier to do those things when the people doing it look like and sound like and have some of the same experiences of the people who we're trying to engage with. So I am just super proud of the team that we have built at ConsejoSano, because it's that team that helps us to do what we do and to do it so well. So the challenge, as I said earlier, that we're dealing with the ConsejoSano, the whole healthcare industry faces, is that our country has changed, and it continues to change. We are on our way to becoming a majority minority country. According to the last census, we'll reach that status as a nation in 2050. If we're able to complete this census and do it accurately, and I know there's a lot of concern about that, I think that number is going to get pulled forward. But the fact is, we're on this journey. There's no going back. This is the America that we have become and we are becoming. And certain states, for example, like California and Texas, that future is already today. California is a majority minority state today. So is Texas. So our healthcare system is, the way it engages with the people it is designed to serve, is really kind of stuck in the 70s. It has not changed, and this is the key point here, it has not changed to reflect these demographic changes. We're still engaging with people and treating people much the same way we did in the 70s. And it's a different a national population now, and we need to do what it takes, and it's not going to be easy, to pull our healthcare system into the present so that it can serve the people that live that call this country home today, and the people that will call this country home in the coming years. Interestingly, the program is the largest health program in the country, the Medicaid program. It is ahead of the curve in many respects. If you look at the 5 largest states, therefore they have the largest Medicaid programs, California being number 1. These programs are overwhelmingly multicultural. As was noted earlier from Kathy, the Medicaid program in California, I think we've got roughly 13 to 14 million members because of the economy. I think the enrollment is going up. It's 81% multicultural. Texas is 79%. New York is 68, and Florida is 66, and Illinois is 62. And those numbers are increasing. And just those 5 states alone, 1/3 of the population of the country lives in these states. 1/3 of the U.S. population. So when I say that our healthcare system is going to have to make changes, it is something that we don't have a choice about. The demographics have changed, and we've got to make sure that we are building a healthcare system going forward that better serves, again, all the people who call this country home. And the reason it's so important for us to start doing that now is because even though we've seen this dramatic demographic change, our healthcare system, like I said, is kind of stuck in the 70s. People joke that, and it's not a joke, it's actually true, that they're still faxing in healthcare. It's one of the only places you can find fax machines at doctor's offices. The way we engage with patients is similar. It's kind of stuck in that old 1.0 model on the left of this slide here, which is all about language. And what that means is when we want to get a patient to do something, we want to get a member to do something, we take a message that was created for English speakers, and then we translate it across, 5, 10, 15, 20 different languages, depending on where you are in the country. And that does check the regulatory box. Agreed that you've done what the regulators say, because they said you need to send the message in the language, but it does not build trust. It does not engage that patient or that member. Because when you do that, when we use the old 1.0 approach, what that says to that member or to that patient is who you are doesn't matter. And when you say that to people, when you say that where they live now, where they come from, their past experience with healthcare, the current challenges they're facing, their hopes, their fears, the biases they bring with them, the myths about healthcare, the social determinants in their life that make it harder for them to access healthcare. When you take all of those things that are part of what make people who they are. In fact, I'd say we believe it's the predominant part of what makes people who they are. It's their culture. It's how they live their lives. It's how they make decisions. When you take all of that and you say, none of that's important, we don't care, and we're going to treat you like we treat everybody. We might translate, usually not well, but that's it. That does not build trust. And what we're saying is that we've got to move beyond that. And that's what we're trying to do at ConsejoSano, moving to this 2.0 model where we start with culture. We don't have a one size fits all. We use data, public data, private data, claims data to figure out who people are, to get an understanding of who they are, and then design content based on that so that when we reach out to someone, we're not saying who you are doesn't matter. In fact, just the opposite. We're saying we've taken the time to figure it out. We want to know more. We want to engage with you based on who you are. And when you do that, you will get better engagement. You'll get better results. And that's what we're doing at ConsejoSano. And we started our work with a focus on multicultural people, meaning people with brown skin or black skin. They come from a different culture. But what we found, and it kind of makes logical sense, is that it's not just multicultural people who want to be treated like they matter. It's everybody. So if you look at this slide, Eldon from Wisconsin, he's a white senior. He's an English speaker from birth. But he's got a whole lot of issues with the health system. He doesn't trust the health system. He's in Kansas. He's a senior. He's got some health issues. He is unique culturally, and we need to respect who he is and meet him where he is, as much as we need to respect and meet Hamina, who lives in Cherry Valley, California. She's of Mexican descent and only speaks Spanish and is a farm worker. Her culture is totally different, the way she makes decisions than Eldon, but both of them are important, and we've got to treat them both like who they are matters. And what the point here is that the approach we took first to reach multicultural people, we've now realized that is the way that everybody deserves, and that's the key word here, deserves to be treated. That people, who they are matters. And if we recognize that and treat them with respect in that way, we will get better results. So how do we do it? How do we do this at scale in particular? Because it's easy for me to find one person and treat them like they matter. But how do you treat 100,000 or 1 million or 10 million or 50 million people like that? And that's the process that we've developed. We built a technology platform at ConsejoSano that allows us to do this. And so I'm going to describe that now. It starts with segmenting the bigger population. We approach engagement by looking at really two threads or two buckets of data. One bucket is cultural determinants, which influence decision-making, and they're shown in green here on this slide. The other bucket is what we call probable life metrics, which are potential environmental barriers, and they're shown in blue here. So it's those two buckets of data, and it's a lot of data that we get that helps us to do this segmenting that we're talking about. Let me talk a little bit more about the probable life metrics part of bucket by looking more closely, as for an example, at Los Angeles County, where I happen to be. We utilize a lot of public data, and most of this is free data to understand what a member or a patient experiences if they live in Los Angeles County, because we can't treat them like they live in New York or in Austin. We got to engage with them like they live in Los Angeles. So we utilize public data to find out at the zip code level, ideally at the neighborhood level, what that person, what their life is like. We call that cultural detailing and resource analysis. But what basically it does is it helps us figure out what that person is facing. So when we engage with them, it sounds like we know them. We've taken the time to understand them. So as an example, using data for Los Angeles County, it's pretty easy to find out that 67% of kids in Los Angeles County are eligible for free or reduced lunches. So what that means to us is, okay, all of our messaging, particularly our COVID messaging when we were doing that, but all of our messaging needs to weave in information about where to get food vouchers, or where the food banks are located in the local community in LA. And LA is a big place, so we want to even get down to the neighborhood. Where's the food bank in your neighborhood? And so that's what it means to meet people where they are and to engage with them in a way that they know you've given thought, you've taken the time to figure out who they are. This other bucket of data is harder to get, the cultural detailing, understanding who people are culturally. So we utilize a mix of firsthand and academic sources. As I said, we built a team. We hire people who come from these communities, who have these experiences, and we use that mix to try to understand how these groups consume healthcare. What are their biases? What are their true beliefs? That, as you probably know, there's a whole lot of myths and misunderstandings, but we have to work with that to build a relationship with people. So for an example, if we're dealing with the Lebanese population in the US, in Lebanon, there are almost no primary care doctors. So a person who's from Lebanon doesn't know what it means to be a primary care. You say, connect with their primary care provider, they don't know what it means. So we have to take the time to explain what a primary care doctor is, what kinds of things you go to that doctor for, why you should go to the primary care doctor instead of the ED, why it's good, the emergency room, why it's good for you to have a primary care relationship. That's an example of sort of understanding where people are and not assuming they know what a primary care physician is, but actually taking the time to explain that to them. So how does all this information come together in our technology platform? Here's just a small example that uses just a few cultural determinants, and here it's culture, language, Tagalog and Mandarin in green, and age. And here we've divided it in between young, middle-aged, and senior. So just 2 cultural determinants, and then just 1 probable life metric, which is in this instance is distance to clinic. And as you can see, our technology platform would take a member population and divide it into about 18 different cultural cohorts. And the point is, we design a different message for each cohort. So just using Daniel, number A, letter A here, he's younger, he's a Filipino, he's urban. So we would reach out to him in a different way than we would Ben, who is a senior Vietnamese, a totally different way of reaching out. We might even use a different modality depending on the situation. So the point is that we are producing a much more customized, personalized experience for members and for patients, and that works. And if you don't believe me, look at what Amazon and Netflix are doing. I always say to people, healthcare is really behind. Other parts of our society have figured this out. If you watch a couple of Netflix shows, I guarantee you they'll start to make recommendations for you, and you watch a few more, before you know it, they will be better at picking what you like than you are. But that's because they're taking the time to understand who you are, they're looking at your choices. All we're saying is we need to bring that kind of technology and that approach, that concern for the consumer, treating the healthcare, the patient like a consumer, we need to bring that to healthcare, and that's what we're doing at ConsejoSano. This is an example of some of the work that we do and what it looks like. In this instance, we've got Juan here who is going to fit in a segment that is English speaking but Hispanic cohort. He's culturally Hispanic, but he actually prefers to speak in English. In this case, we're texting him, since asynchronous communication is really better for hourly wage workers. But if he was a senior, we might actually call him instead of texting him. But we're texting him. We're highlighting that telehealth is a great way to get healthcare services in the era of COVID. And we even provide a link in the text message that he can click on and see what the COVID precautions are at the clinic that he's going to, not someone else's clinic, but the clinic that he's going to. And last year, you can see an example of where we're talking to him about coming in for a routine A1C test. We can allow him to click the clinic. He can click in the text message and make the appointment, or he can even tell us he's already had his A1C test, and so we can share that information back with Anthem. What we do is two-way, although most of it, people don't often respond, because most of what we're trying to get people to do is take an action, not to respond to us, but to make an appointment, or we're just educating them. This is an example. This slide here just talks about the impact we're having. It's pretty extraordinary that when you treat people like who they are matters, it really does get higher engagement. With one of our clients, we were able to close about 40% of well child visit gaps. And this is a Medicaid managed care plan client. They struggled to get these kids in for their annual well child visit, which is required in the Medicaid program. Using our approach, we were able to close 40% of the gaps. And these are, again, from people who they'd already tried to reach and hadn't had success. The second example I'll touch on is, never seens, we call them. These are people who haven't had an appointment in over 12 months. In some cases, 2 years and 3 years since they've been in. The clinic had tried everything to get them in, but when we reached out and connected with them culturally in a way that built that trust, we were able to get 40% of these never seens to make appointments. And then finally, something I'm really proud of is when COVID first hit, a lot of our FQHC, meaning federally qualified health center clients, these are the safety net providers, of course, people couldn't come in for visits, right? And in the past, telehealth was not reimbursed. Well, the regulators, which was a mistake, but the regulators made a change because of COVID, and they allowed reimbursement for telehealth visits for these FQHCs. Many of them are the Anthem partners we work with. And we were able to generate 50,000 telehealth visits in about 4 to 5 months. And again, these are telehealth visits with Medicaid folks. They're low income, low health literacy, many English is not a first language. We were getting them to use a new technology for the first time. And it not only helped them to get access to healthcare, but it helped to keep these federally qualified health centers to keep their doors open, because they were not getting paid because no one could come in initially, right? In COVID first hit. And even when the regulation changed, if you couldn't get people to use telehealth, you still couldn't get paid. And so they were going to close their doors. And I'm just proud of what we were able to do with Anthem's support with these clinics to generate these kind of telehealth visits. I'll move to the next slide. We have a range of clients that we're proud to work with, obviously including Anthem, but also Anthem's, the clinics. Anthem came up with a creative program, which Joel will talk more about, that allows us to work with their clinic partners. And we're proud of the work that we're doing with them. We're really getting great results. I'll talk just a minute about some of the results with those clinics, with the Anthem members. We're engaging about 112,000 across 4 different clinics. We've sent out just under 600,000 text messages. We have, Joel will share more about some of the actual data, but it's great. We're having a really good impact. We're expanding with those clinics. I'll just touch on the inbound. As I said, we don't get a lot of inbound because almost half of our messaging is educational, that you should do this, or you need to do that. So there's no reason for them to reach back out to us. And then a good part of our messages include a link, not to us, but to the clinic to make an appointment, or to the breast cancer screening center to make an appointment for breast cancer screening. So even though it's two-way and we are open to it, we don't get nearly as much two-way, but what people are doing is they're taking action that we want them to take. And so I'll close here, but let me just close with saying one thing. The trust that we're trying to build is really needed now. COVID has hit the whole country, and it's a profound example for us. It's destroyed our economy. It's turned our lives upside down. But if I saw a poll yesterday, if you ask Americans, would they take a vaccine? The vast majority of African Americans say no, over 70%. Over 60% of Hispanics say no. What that means is we've got a trust problem in healthcare. If you had a vaccine, people wouldn't take it today. And so I would just want to commend Joel Gray from Anthem. A lot of big plans, are in a position to do something about this, and I think they've moved too slowly. I'm hoping in the future they'll move more quickly, but I can't put Anthem in that group because Joel's leadership here, he knows the challenges that we face with the multicultural population, and he's actually taken action. He's not just talking about it, he's taken action to produce some great results. So let me close by passing this off to Joel, but also thanking him for his leadership, because if it weren't for Joel, none of this work would be happening. I'm going to stop my screen share, and pass it off to Joel.
Thanks, Abner. I appreciate that. So let me see if I can seamlessly switch over to my presentation here. All right, did that come up okay?
Perfect.
Great, thanks, Abner. And I appreciate all the kind words, but it kind of goes right back at you and kind of your organization. And it's really organizations that are like what ConsejoSano are doing in the focus that's really delivering the goods here. So I don't want to take any credit here for all of the good work that you and all the health centers and the collaboration. I'm actually not going to go too deep into the work that we've done with ConsejoSano. I'm going to kind of bridge it all together in some other projects and programs, but I will say this for those listening in. One thing that health plans struggle with patient engagement is the regulatory environment that we're under. Makes it a little bit more difficult for us to get approval to do campaigns to begin with. So we took an out-of-the-box approach with ConsejoSano and partnered with multiple FQHCs, or safety net health centers here in California, to leverage an innovative P4P or incentive program that clinics could earn money more upfront to have budget to essentially engage ConsejoSano with our recommendation. So it's like a three-way collaboration. We're not directly funding it, but kind of indirectly. And it really has produced some amazing gains for the health centers that are participating in this. Is kind of that slide that Abner talked about. So could have a whole presentation just on that collaboration, but just a little bit of a teaser for this one. So I'm going to go ahead and start with just a quick introduction for our health plan here. So let me just go over our organization. So I'm an executive director with Anthem Blue Cross. I'm sorry, I'm going to switch my headset here because this is the modern tech age and we have to have batteries and everything. So we are a large Medicaid health plan. We operate in 29 urban and rural counties here in California. We serve 1.2 million lives in this geographic footprint. So a fairly large Medi-Cal plan here, one of the largest in California. And for my presentation, I'm really going to go more into our partnerships with providers and vendors to help solve for the challenges that cultural and language barriers are creating in healthcare. And can you still hear me okay? Just a thumbs up. Okay, great. And Abner talked a lot about that, so I won't try to repeat too much of what he said. But yeah, I really do love what ConsejoSano is doing and how effective they are in building and establishing trust with people of different cultures who speak many different languages. And this ultimately, as Abner said, helps those people better engage with their healthcare. But that success that ConsejoSano does here in building that trust kind of leads to a different question that I'm going to explore in my presentation. So what do we do when ConsejoSano's engagement work does lead to a patient with, say, limited or no English proficiency arriving for their appointment at their doctor's office, and then there aren't any staff that actually speak that person's language? And so for me, this is actually a very personal question. And one thing I'd like to do, this is now the world of Zoom meetings, but I wish I could just have everyone raise their hand and just let me know, have you ever had to help interpret for a friend or a family member for their healthcare needs? And you can go to the chat box and just say yes. We don't have to do this as an official question. Or if you haven't had to do that directly, do you know of any family members or friends that have experienced language barriers like this in healthcare where they really did need interpretation services? So a little participation from everybody here, and we'll kind of look at how many people said yes, but I definitely have. And I find with my own staff, this is a very personal matter for them. Again, look at the ever evolving multicultural populations and the growth in those populations. And I think almost everybody has experienced this. So a very, very meaningful and timely subject for all of us. So what I want to actually do is share my personal story about why our work in this space, what ConsejoSano is doing, what Anthem is doing, why this is kind of personal to me. So the story really starts with a good friend of my wife, who I'm just going to call Bia. My wife, she's a Thai native and a bit of a linguist. She has a degree and speaks French. She's learned English, and of course, she speaks Thai as her first language. And I'll just say, I think I know about 20 words of Thai, including Sabadi Mai Cup, and that's how are you, for anyone who's actually been to Thailand. So if you ever met Bia, who is also Thai, you'd find that she has an accent, but she speaks conversational English really well. She had been experiencing all of a sudden some extreme fatigue and difficulty lifting things with her arm, and it happened suddenly and really for no reason. I think the symptoms were bad enough that a lot of people probably just would have gone to their doctor in the first week or two, but she actually waited a couple of months before going and ended up trying to push through it because ultimately she didn't have a relationship or any trust with a doctor, didn't have a doctor accessible that spoke her language, and I think just ultimately hoped it would go away. And of course it didn't. But she eventually did go to the doctor, and that was at a point where she could actually barely work anymore. And the doctor visit actually didn't go very well. She felt like they really weren't understanding how serious the condition was for her, and she even went for a second visit. And ultimately, those visits resulted in being advised to get more sleep, try to use the arm less, just use your other arm, and try a prescription and an order to see a physical therapist. And so Bia ended up having to take a month off of work because of how bad that this got. So my wife actually asked me to help, and we had a call together with Bia. And again, I've always known Bia to be able to speak great conversational English, but she really did struggle to explain her medical condition. And so my wife kind of helped interpret between us. And it really did help me immediately understand in a very personal way why her doctor would likely have thought that this probably wasn't serious. So again, while Bia has a large, I'd say very large English vocabulary for conversations, her medical vocabulary, or sometimes we call health literacy, was definitely more basic. So for example, rather than say things like, I'm having a lot of malaise or extreme fatigue, she really can only say, I felt tired a lot. And instead of saying her arm is extremely weak and lifting things is almost impossible, she would say that my arm is tired or not strong. And lastly, instead of saying things like, this is dramatically impacting my quality of life and I can barely function at work, I could lose my job, she would say things more like, it's hard to do my job, it's hard to go to work. So she was in another state. We first started by helping her write down what her symptoms were and how and much stronger words around severity. And she shared that with her doctor on another appointment. And that immediately led to an order for an MRI, for a CAT scan. And they actually, and unfortunately, found a brain tumor. Now, fortunately in this story, and this was very scary for all of us, it had a really good ending. It ended up being a benign tumor. A treatment plan was established and it was very successful. She's back to work and symptom-free now. But the story, I share all this because there's so many other people that have language or culture barriers that are, I would say, similar to Bia's, and they don't have someone to ask for help like she did, or they might even feel shame or anxiety to even ask for that kind of help or interpretation. And that's even assuming that they would know that they can ask for language assistance at their doctor's appointment. And this experience also kind of helped me understand that clinicians may not even realize how much of a language barrier actually even exists with a patient that maybe appears to speak and understand English well enough and wouldn't even know to offer interpretation services. And you kind of put this all together, and I feel like it can lead to far worse outcomes than the story that I just shared for BF. So Abner and I, we've summarized all of the different challenges that we're faced with here that occur with cultural and language barriers. And of course, it makes it very difficult to have successful patient engagement, especially in multicultural populations, which then ultimately leads to a lot of the race and ethnic disparities that are getting a lot of attention today, fortunately. And there's just a couple here, on the right that you can look at. For example, cervical cancer, Hispanic women being twice as likely as a white woman to have cervical cancer. And there's so many examples of this, and I know it's a challenge that we're all tackling. And I won't repeat too much here, but if we don't find solutions to these disparities, the problem is just going to keep getting worse as we get through 2050. So as Abner mentioned already, our country is becoming more multicultural. And by 2040 to 2050, more than half of the people in America are going to be multicultural. So Abner talked about Anthem's partnership with ConsejoSano and the health centers on multicultural patient engagement. And I think of that as what Abner's company does, and it's really great work, is it helps get people the last mile to their doctor's appointment, people who have limited English proficiency especially, and they have a lot of success. and really proud to be a part of that and actually seeing it affect and impact so many people's lives successfully here. So what I'm going to go into for the remainder of my presentation is talk about Anthem's partnership with a company called LanguageLine Solutions. And again, our health centers, these are predominantly FQHCs, regional health centers, Indian health centers that we partnered with on this. And what it does is it allows people like my friend Bia to access an interpreter on demand when they arrive at their primary care doctor's appointment. So to just kind of walk through this on this slide, this is actually a summary slide that we actually put directly in front of safety net health centers to kind of explain it at a glance. We have a lot more program materials on this. But what you'll see here is in the middle, there's a rolling cart with an iPad basically sitting on top of it. And what we decided to do is procure several hundred of these and offer them at no charge to our health centers. And what we would do, though, is it's not like we were just giving these away. It was something where we would have our IT folks configure them as a kiosk. So there's no password, then they turn on. The interpretation app and software would just be right on the app when you turn it on. And we could actually administer that remotely to reduce the administrative complexity for IT teams to kind of configure this and make these things actually work. And so what this does is it allows, when a patient walks in, someone like Bia, if interpretation services are needed at any point in time during that primary care visit, a clinician, a nurse, a mid-level, the doctor can just immediately push one button. You see the lower left, it's a little snapshot of what the app looks like. Pick a language, and they can pick video or audio. And within seconds, an interpreter can come on the screen if the patient prefers video, or if they don't, they can just be audio. you can see on the lower right-hand slide here that LanguageLine, you know, has actually amazing interpreters. I think they have over 10,000, if I remember correctly, all over the world, which are actually creating jobs for multicultural people and raising them out of poverty, which I think is fantastic. They have 40 languages in video. I think it's actually more than that now. They have over 240 in audio. And they're even doing telephonic work during this COVID crisis. And most importantly, there's no cost to the health centers involved for reimbursing for these minutes. What we ended up working out was a solution where the interpreters would collect the insurance ID at the time of the visit and then bill Anthem on the back end and go ahead and reimburse that directly. So this is a huge improvement to the way that I would say a lot of health plans, and this isn't just California, this is nationally, about how they reimburse for interpretation services. I'll kind of borrow a little bit from Abner and saying kind of 1.0 and you know, we're kind of stuck in the Stone Ages. A lot of health plans right now, and Medicaid especially, what we offer is in-person interpretation services. And you know, in-person interpretation sounds like the gold standard, and actually it is, but it's very inefficient in healthcare delivery systems for a lot of reasons. You have actually, you know, the clinic has to do extra scheduling with yet another person to arrive at the same time, so there's more coordination. There's potentially a lot of waste for in-person interpreters. A lot of the vendors that do in-person, they have minimum, it could be like 2-hour blocks. So no matter if the appointment's 15 or 30 minutes, you got to pay for 2 hours. And if there's a no-show, which on the Medicaid side, we tend to see higher no-show rates, there's still, you got to pay for that minimum block. So again, there's a little bit of waste on the cost for the delivery systems, but you know, a lot of the health centers that I've met with in their leadership don't particularly like in person because of the extra complexity it adds in trying to schedule a patient in the first place. The other way that we offer it is there's a call center where if a person shows up and needs it, needs interpreters, you can call a call center and wait on hold and speak to a health plan associate who can then bridge in a 3-way call to an interpretation services and bridge the call together. But the problem with that is a lot of doctors' offices, their exam rooms don't have a phone to begin with. And when I go in there, I rarely ever see a phone. So when this was being done, sometimes the doctor would have the patient use their phone, or the doctor would use their own personal phone, which is really not ideal. And then there's the hold time. You know, if you're calling a call center and trying to do this, it could end up taking a very long time to get an interpreter on the line. So again, huge improvement to have on-demand interpretation. And what's interesting is that, like, this is not new. I'm not describing anything groundbreaking here. Hospitals have actually adopted services like this quite a while ago. And we've even seen some primary care clinics actually, they love this so much and think the need's so great that they were actually paying out of their own budget. Even if health plans could do it a different way, they were actually paying out of their own revenue to basically install this inside their health centers and their exam rooms. So again, huge improvement for everybody. And it's one of those rare solutions where it's kind of like, why aren't we just doing this in healthcare, you know, across the country, not just California? Like, why? This technology is so easy. Everyone loves it. Patients love it. Doctors love it. Hospitals love it. Insurance companies love it, right? Like, it's one of those rare solutions where everyone can come together and say, this is the right way to do it. And the problem really is, as I try to explore getting this off the ground for Anthem, is that really no vendor nationally had built their company or their business models around integrating with healthcare systems, highly complex reimbursement models. How do you separate out the minutes and the utilization for one health plan versus the other, and then build that and get reimbursed? So that was really the challenge. And I met with a lot of vendors to say, let's solve for that. This is a great program. Let's just do this. And initially, all the vendors I met with said, no, we can't do this. It would blow up their accounting systems. It would blow up their IT systems. I heard words like impossible, and this would be a fairy tale. It sounds great, but it's just too complex. But after meeting with several of them, eventually LanguageLine stepped up, and I want to give a shout out to them and kudos to them because they took a big risk. They put a lot of projects on hold, a lot of their IT roadmap, and eventually said, you know what, we see meaning in this, let's try to do it. So they did that. They did a phase 1 approach with us. Again, very basic. Interpreter gets on the line and says, what's your health plan? What is your ID? And the clinic would eventually they would just give that over the phone basically through the interpretation. And then we would get billed on the back end. And it's been such a big success that LanguageLine's already close to a phase 2 on this. and we're going to be doing real-time eligibility lookups where you can just plug in on the iPad the ID of a member, and it'll just do a real-time eligibility lookup to the health plan. And the other neat thing about this is that this can work with any health plan. We already have some discussions with some other county-run or community-type health plans that find this fascinating, and we're thinking about doing some partnerships soon with them. And I could actually see this gaining a foothold and growing, at a national level. We're the first health plan to kind of do it this way that I know of, at least in the California market. But again, I think this could end up being a bigger deal. And then lastly, on the solution in the upper right-hand corner, during COVID, we saw an opportunity to have this facilitate better telehealth visits. So a lot of clinics were saying, hey, we're not having people come into the clinic as much anymore because of COVID, but we see that these things, we can roll them around and a doctor could use them as a second screen and just connect with a patient remotely. So we installed all the video conferencing apps that are pretty popular, and that's actually continuing to grow. Things like Zoom, things like Teams, Doxy, and so on. And that's actually added even more value to the solution. And then we actually married the interpretation service to the telehealth, so it's actually combined. What LanguageLine has done is enabled a way for apps like Zoom to do a three-way call to a dedicated phone number, and computer says, what language do you want? And you say, and then it can bring the interpreter into the telehealth visit. So you're kind of marrying both of these projects, telehealth and interpretation services on demand for patients. Again, I'm sure, as you all can understand, it's a huge benefit. So let me go on to the next slide. This is a pretty new program, but I did want to at least we talked a little bit about, how this can help populations. I want to show some of the outcomes here. We did a soft launch in Q4 of last year, just to it was more of a proof of concept, and it was very clear that this was going to be a success. So as we went into Q1, we focused on launching in Q1 a bigger program, getting more of these kiosks out into the market. We have over 300 already installed across 120 clinics, if you can imagine this, in California already. And it has been exponential growth since then. I mean, we started in February, really, is when it started to take off, and you can just see the growth and how many lives have been impacted by this. These are real people, just like Bia, who are, being profoundly impacted by having this service. You can then also see that in 6 months alone, we've reimbursed over 40,000 minutes. And then what's really interesting about this is several of the health centers participating in this program were, again, paying for this out of their own pocket. And so for every minute we reimburse now, we're actually directly dollar for dollar saving money for those health centers, freeing up, revenue and dollars for other important projects for the underserved populations. So again, really excited to see this continue to take off and continue to see it grow. My last slide here, and we'll open it up to Q&A, is I just want to share that there is an article that was published on this project in CalHIPSO, which is a tech-focused newsletter for health centers. And so if you wanted to learn a little bit more about this, this is a little bit more of an under the hood about the problems we had to solve to get this off the ground that I just kind of give a teaser for. There's some links over there. If you just Google CalHIPSO and kiosks and Anthem, it'll probably just come right up. So just wanted to share that as well. So I will go ahead and end there and get our moderators back on, and I'll see if anybody has any questions for us.
Well, I'll get started. This is Kathy. I see we have a question from one of our attendees that asks, how does this system compare with traditional LanguageLine interpreting services, where a physician calls the interpreting service when the patient is present for in-person visit in terms of cost and effectiveness? I believe that's a Joel question.
Sure. Yeah, I'd say definitely better because, again, making the phone call alone, well, it depends, right? If you have a direct line where you can just call the interpretation service directly, that's great. But again, it depends on, do you have a phone in your exam room when you're trying to do this? And again, I find that a lot of clinics don't. So by having an iPad that you can just roll around or put inside an exam room and just turn it on and click a button, this takes a couple seconds, you can still get audio only. And from a price point perspective, it would be very similar to the telephonic only if you're just doing this over the phone. And again, what phone are you using? Are you using your phone? I know this screen thing doesn't show my phone very well, but are you taking a phone and putting it on speakerphone and putting it down on the ground? Well, let me just say the audio quality is kind of terrible when you put speakerphone on, say, a cell phone. iPads, the ones that we've used we're using the iPad Pro model, which is a fantastic, give a little plug to Apple here. Fantastic device in the healthcare setting. It has 5 microphones all around it. So what we found with testing it is that a doctor can be behind it and the patient can be in front of it, and the audio clarity of the interpreter is amazing. And then the sound of the interpreter has a natural sounding voice rather than something tinny that comes out of a phone. So again, even for audio only, I think that using it on like a kiosk like this is a better experience for the patient. Again, even if the costs are the same. But then you get back to having a video option. So by having a kiosk, there are situations where video is just going to be better, depending on the condition or the situation. And then I'll even add for, you know, ASL or sign language, you have to have video. And so you kind of have that option. So this just kind of gives you the best of all those worlds. It's just immediately available and at your fingertips. But I don't want to discount having a telephonic option. That's equally important because in any setting, especially a telehealth visit, having a telephone option to bridge in an interpreter is also valuable.
Thanks, Joel. Another question that came up was from Gina Bright, who's asking, how does any given practice procure the kiosk program enrolling iPad, and who is our contact?
So it's a very good question, and we'll probably have to send out some follow-up materials on that. I do have a program lead that helps, you know, kind of lead this whole program. His name's Wyatt Fountain, and we can get some emails out on kind of if you're interested. But generally, I would say if you have a contact at Anthem, it could be your quality lead, it could be your provider relations lead. Everyone in Anthem Blue Cross on the Medicaid health plan is fully aware of this project and very supportive. So reach out to your normal contact, and if you're interested, we'd love to have a conversation with you.
That's great. And I think this question is for both of you gentlemen. What are some strategies for very small healthcare practices to increase and improve engagement with multicultural patients? You
want to go first, Abner?
Sure. So if you're lucky enough to be working with Anthem or be in, you know, a clinic partner or provider partner for Anthem, a program like ours where we do the outreach, I think one of the things that I maybe didn't make as clear is that I think one of the reasons we were selected to partner with Anthem on this program is that we are a soup to nuts solution. Most small healthcare practices or even larger, you know, provider practices, they have their hands full just seeing patients. And so to ask them to become experts on who their patients are culturally, design the content, send that out in the appropriate mode, you know, text messaging. It's just a heavy lift for most practices. They don't have the time. They're doing the best they can and doing a great job of just providing the healthcare, but they don't have the time to do what we do. And so that's why our solution is soup to nuts. As I say, we get the patient file, we create the content, we get it approved by the provider. So we never send anything to anyone's member or patient without them approving it. But once they give the thumbs up, then we send out that content. We could do the back and forth as appropriate. We then collect the results and share back with the provider and the plan. So if you're an Anthem in the Anthem network and your provider in the Medicaid program, you know, talk to Joel or talk to us. We'd love to work with you. But what we're finding is that other plans, and this is, you know, I give Joel and Anthem credit. And now other plans are starting to see that the old way of approaching this just isn't working, and they also need to follow Anthem's lead here. So I just encourage you, if you've got a practice, talk to the health plans you work with, because it's in their interest as well as yours to make sure that these multicultural patients are seen appropriately.
Thank you. Another question that came in is something that I'm sure a lot of people are wondering is, I work with underserved populations who often don't have phones or have them but can't afford to pay for texting or minutes. Any ideas as to how we can better work with them using telehealth? We use Doxy when they have the internet and an appropriate device, but when they don't, we're stuck.
Sure. You don't want to take that, Joel, or?
I think we might, you know, both have some thoughts on that. I mean, I definitely am a fan of the low-income phone programs that are available in many states. I know California has one. I believe it's called Lifeline. So definitely encourage, you know, more engagement in trying to help people sign up for that service. There's actually a family member on Medicaid who has benefited from that program, and I think that can help a lot. It doesn't give a ton of data, and there is an option to pay a little bit of money, and it can increase the data just a little bit. But I'd say like anything helps. It's a huge challenge, though, especially in rural areas, and it's actually something on my radar, and looking for different products and solutions that can really help with getting more Wi-Fi coverage. I mean, you're even seeing this right now with schools. I mean, like the version of telehealth, but for schools, it's like you're hearing about the Taco Bell stories and kids having to use, internet at fast food restaurants. And I think there's a great opportunity even for health plans to consider different programs that could expand hotspots or Wi-Fi access. So kind of considering some of those things, but it is tough. I'm glad right now, I will say that through the emergency declarations, a lot can be done through telephonic visits right now. And we don't know when that's going to end, but I'd say all the health plans that I know of, we're all on board with that, and reimbursing for those kinds of visits. I would say let's leverage that as long as possible while we continue to work together on finding better solutions. Abner, I don't know if you want anything else to add.
Sure, just two quick things. One is that what we're finding increasingly is that regulators, the Medicaid program in particular, regulators are requiring that the text message be paid for by us, the sender. So more often than not, and this is the case in California, it's one of the requirements. So now it's for us, it's not a big, I guess the term is de minimis. It's not very, when you're sending a volume of text messages, the cost to us, we build it into the program, is not very much. But just to be clear, the patient doesn't pay, the member doesn't pay. We pay for, we cover the cost of it. It's free to the end user. Free to end user texting. So that's number one. And then number two, in terms of people who can't text or who are uncomfortable texting, even if they can, we have live outbound calls that we do here. We have a team of people who come from the communities we serve. They come from the cultures and speak the languages. That is a small percentage of our engagement, but we have built that team because it is necessary both for people who fall in that category of maybe they physically can't text, or they just are more comfortable talking with someone. That's particularly true for much older people. I think you'd be surprised that seniors who are in the 65 to 75 range are texting. They're comfortable with it. But once you get above that group, for some of the, the duals that we work with or the Medicare Advantage folks we work with, they prefer to talk. So we offer that because you got to meet patients where they are, right? The whole point here is to build trust. So we shouldn't be saying to patients, you have to communicate the way we want you to communicate. What we should be saying is, how do you want to communicate? And we'll meet you there. We'll do that.
I think, Abner, you must be sneaking a peek at the Q&A box at the bottom, because I believe you just answered for telehealth visits, have you found patient digital literacy skills an issue? And I think that's yes, and how you've overcome some of that. How do you text patients in a way that's HIPAA compliant, or is texting without PHI okay with regard to HIPAA?
It's typically okay if you don't have PHI in the text, and we can design our text messages so that they either, depending on whose definition you use a PHI, they don't have it, or we comply with the state regulator. So the key here is for the Medicaid program, which is a lot of what we're talking about, it's regulated by state. So you have to work with the regulators in the state. We do have this problem with text messaging, that there's a federal law that is in the way. And let me make a pitch here. There's a federal law called the Telephone Consumer Protection Act. It was passed in 1992. It was the year I think the first text message was sent. So fast forward to now, where text messaging has become the common way people communicate. That law from 1992, which is federal law, still on the books, needs to be changed. It needs to be scrapped. It is a huge constraint on the ability of healthcare providers and plans to communicate with their members in 2020. So that 1992 law, the Telephone Consumer Protection Act, it needs to be changed. It is a constraint, but we are finding ways to work around it. But the fact that we have to find ways to work around an old law is really kind of silly in 2020. And so we need to change that law. But we can work around it. We find ways to work around it. Go ahead, Joel.
Yeah, and I know I'll add everything Abner said is spot on. But on HIPAA, there is rules in there that do allow patient engagement work, including text messaging, to occur even without consent, as long as it's considered for health like healthcare operations, which generally means health or quality related. So we continue to navigate on that. Abner has great, advice and documentation on kind of how that all works. But yeah, I definitely also want to support back to what Abner was saying about text messaging and some of the earlier questions. I mean, it is a universal platform for communication, and I definitely feel like that is the area we need to focus on. I think most healthcare systems need to really have strong text messaging communication platforms, whether it's through something like what Abner's company does around campaigns and engagement work. It could be your own call centers. It's just I think it still continues to be a huge opportunity for our healthcare systems to modernize.
Thank you, both of you. Let's ask another question now. This is a really big question, so feel free to bullet point it or say, wow, this could be discussed in a future conference. But what are some of the strategies for very small healthcare practices to increase and improve engagement with multicultural patients?
You want to take that, or Joel?
I mean, it's kind of the same thing. I'll just go back to text messaging as being a great opportunity that could be low cost. But no, Abner, I think you're better suited for that one.
Sure. So I'll kind of repeat. We are finding several instances across the country where small practices have wanted to use our service, for example, but couldn't afford it, and they have gone to their the health plans who send patients to them that they have contracts with to provide care to their patients, and they've worked out an arrangement with their patients. Nothing as groundbreaking as what Joel has done with Anthem in California, but there are other providers across the country who, and I think, are actually seeing what Joel has done in California and saying, why can't we do this? Why can't we get our health plan to partner with us in a similar way? So there's an old saying, they used to ask people, why do bank robbers rob banks? And the guy said, because that's where the money is. I think, and Joel might hit me for saying this, but the health plans have a really important role to play in healthcare, and a lot of the dollars flow through them. And so I think providers should reach out to their health plans and say, let's partner. We're in this together. We're not opposite sides. We're in this together. And I think that's what's so unique about what Joel has done, that he's partnered with their provider network, and they're working together. I think that's a way to get a lot done.
I think that's
yeah. Yeah, I think, and I can just add to that as well, because even if you're a small clinic, if you happen to be part of some kind of an incentive program where you can earn dollars, whether it's from medical groups or through your health plan directly, that's something to really take a hard look at. What I like about Abner and ConsejoSano is that you're essentially, as a smaller organization, you don't necessarily have the bandwidth to build very robust campaigns and all the infrastructure to actually run very successful external campaigns, especially multiculturally competent campaigns. So I like that you can kind of subcontract to an organization like ConsejoSano, but then they white label it. They basically still text as if it's coming from your clinic. They're not saying, hi, this is Joel from ConsejoSano. They're saying, hi, this is Joel from Amazing Clinic, right? So I think there's an opportunity to try to look at dollars you're earning and then look at programs like ConsejoSano's. But if you're a large organization, some of them take this in-house and they decide to build it. Either way, though, I think it's important to make sure you're maximizing and earning those incentive dollars to then fund programs like this. And I'll also add that some health centers have actually been able to find an ROI in some of these. So something I try to underscore a lot to clinics is focus on the re-engagement type campaigns, sometimes called disengaged members who haven't accessed their healthcare in years or a year. And if campaigns can actually bring those people into the office to close gaps in care, you can actually calculate that as a direct ROI, that those visits most likely occurred because of this campaign work, which is net revenue for your organization, which kind of justifies the cost even doing all this. So those would be two things I think I'll add, Abner.
Great.
That's great, both of you. And I know we have a hard stop in just 1 minute. I saved my questions for last, but there were so many questions I didn't get a chance to ask my own. So thank you both very much for joining us today. And this is very important information. And as we all know, that the culture is our strength in California, and it's thanks to groups like yours that really help us to keep our citizens healthy and safe. So thank you again for joining us, and thank you everyone for joining us.
Thanks. So long.
Thank you, everybody.
Yep, thanks.